Assessment of the cardiovascular system. Okay, so we're going to talk a little bit about anatomy of the heart, the coronary circulation. So the heart muscle is fed by coronary arteries. So we'll talk a little bit about those arteries. We will talk about the difference between arteries, veins, and capillaries. We'll talk a little bit about blood pressure. We'll look at an EKG and talk about what's happening in the heart as we're watching that waveform go across the screen. We'll talk about assessment data that we want to gather from the patient or the caregiver. We will talk about a physical assessment of the cardiovascular system. That's really a review of health assessment. The second one on this screen is also a review, but it is important to be able to distinguish what's normal and what's abnormal when you do a physical assessment. We'll talk about some age-related changes, and then we'll spend more time talking about the diagnostic studies that are used for the cardiovascular system. There's quite a few things that we can do to look at what's going on in the heart. So these are some things that we're going to talk about today: the structure, the blood flow through the heart, how does the blood that's going to the brain and the body flow through the heart and through the lungs. And then we'll talk about how does the heart muscle itself get blood. So starting out, this is a cut section. If we cut through the heart down the middle, we can see the right atrium, the left atrium, the right ventricle, and the left ventricle. And just as a reminder, the left ventricle pumps to the brain and the body, and the right ventricle pumps to the lungs. And you can see that the pulmonary artery here is colored purple, and that's because this blood is not oxygenated. This is the only artery in the body, pulmonary artery, that carries deoxygenated blood. So that's why it's purple. All the other arteries are going to be red. And then you can see that this side, the superior vena cava, the inferior vena cava, and the right atrium are colored bluish purple, and these are the largest veins in the body, superior and inferior vena cava. And so this blood is deoxygenated. It's returning to the heart so that it can be pumped to the lungs. Then it returns to the heart, comes into the left atrium, left ventricle, and then is pumped through the aortic valve into the aorta up to the brain and the arms and the legs. Okay, the aorta comes down behind the heart and then goes to the rest of the body, the lower extremities. You can see blood flow through the heart, how a blood cell, if we were following just one blood cell through the whole body, how the path of blood continues through deoxygenated blood enters the right atrium, goes to the right ventricle to the lungs, where it's oxygenated, and then back into the heart, where it goes through the left side of the heart and out to the rest of the body. And then the heart muscle itself needs blood flow. And so there are arteries on the surface of the heart called coronary arteries, and they feed the heart muscle. They bring oxygen and nutrients to that heart muscle. And then, of course, we have coronary veins as well that drain, that take all the waste products back into the circulation. So they take them right into the right atrium and join the deoxygenated blood from the rest of the body. The right side, the right coronary artery over here, this is going to be more, if there's an issue over here, it's more likely to affect the electrical system of the heart, because the electrical system of the heart, a lot of it is located on the right side of the heart. So when we have right side issues, right coronary artery issues, we're more likely to have EKG problems, arrhythmias, dysrhythmias, Okay, if this side's affected, the left side of the heart, if something happens to the left coronary artery, then we're going to have trouble pumping blood to the body, more likely to have heart failure. The left side is a lot stronger. It's thicker walled. It has to pump harder. So when we have issues on the left side, we're more likely to have, they kind of call them plumbing issues, but trouble pumping the blood where it needs to go. Okay, so this picture shows what is happening in the heart when we look at an EKG. So the P wave, this little upward deflection here, that is the atria contracting. And the atria contract at about the same time. The SA node, that's what starts the heartbeat. In a healthy person, it usually fires between 60 to 100 times a minute. It starts the whole conduction process, helps the right and left atria contract around the same time, and then the blood moves into the left ventricle. The AV node, once the electrical activity, once it reaches to the AV node, it travels down the ventricular septum, this area in between the two ventricles, and then out through the bundle branches. And when the bundle branches contract, that's when the ventricles contract. And those also contract at the same time. So you can see the P wave, that's the atria contracting. Then we have a short pause while the impulse goes through the AV node, and then it goes through the bundle branches, and we have this huge contraction. This is the ventricles. You can see much, much bigger than what's happening over here. And then we need some time for those electrical cells, those cardiac cells, to reset and get ready to accept another impulse. And so that's what we see here. And we see that wave kind of doing the inverse. So here it's accepting an impulse and contracting in the P wave and the QRS wave, and then it's resetting, and then here it's kind of doing the inverse. I know that's weird. It seems like it should go down, but it's getting ready to accept another impulse from the SA node. Okay, and then we'll see another P wave when the atria contract. And depending on how long, they have some measurements here that we might measure, and that could tell us if there's a problem with the heart, if things are taking too long, if there's too long of a pause, or we're extending the time from when the heart contracts to when it repolarizes. That can also cause some issues. Okay, so let's talk about the mechanical system of the heart and some words that we use when we talk about the heart. So systole, we'll talk about systolic blood pressure. That's the higher number. Systole is when the ventricles are contracting and ejecting blood from the heart. So that's why blood pressure is higher, because the ventricles are putting that pressure on the artery by forcefully pumping out that blood. Diastole, or the diastolic blood pressure, that's the lower number, and that's when the ventricles are relaxed. So they're taking a break, they're getting ready to fill again. The atria are contracting and filling up the ventricles with blood, and so that there's not as much pressure exerted on the arteries because the ventricles are relaxed. Stroke volume is how much blood leaves the ventricle each time it beats. So one heartbeat, the heart ejects that volume of blood. Usually we're looking at the left ventricle when we talk about stroke volume. Cardiac output is just taking that stroke volume and figuring out over a minute how much blood is leaving the left ventricle. And so we do that by taking the stroke volume and multiplying it by the heart rate, which is the beats per minute, and that tells us how much blood is ejected from the heart. So some things that are going to affect our cardiac output: how much blood is already in the ventricles. when we're getting ready to contract. If we have a large volume of blood, it's going to make it harder for the heart to get all of that blood volume out. Okay, so that's preload. How hard is the ventricle contracting? That's contractility. How hard is it squeezing? When we have sympathetic nervous system activation and everything is sped up, the heart is pumping stronger. Okay, so that's going to make more blood flow leave the ventricles. And then afterload, a lot of this is related to blood pressure. So if someone has a high blood pressure, then the heart really has to push harder to overcome that. And so afterload can also decrease cardiac output. Cardiac reserve is just the ability of the heart to react to stress on it. Say if you decide you have to run, you have a little bit of cardiac reserve. You can increase your cardiac output in response to a crisis or exercise. Okay, so the vascular system, this should be a review. Remember that arteries have very thick muscular walls, and so they change shape easily in response to blood pressure and various other things. They can vasodilate and they can vasoconstrict. Veins and venules are very stretchy. They don't have muscle, and so they can actually get very large and store blood if it's needed. If the heart is under a lot of stress, sometimes blood will be kind of left in the veins. They'll get real distended inside where you can't see it, and they can actually kind of prevent stress on the heart from too much blood flow. But they do not vasoconstrict and vasodilate like arteries do because they don't have that muscle layer. And then capillaries are the connection between arteries and veins. So the cardiovascular system is regulated a couple different ways. The sympathetic and parasympathetic systems, they're part of the autonomic nervous system. And they, the sympathetic, you can remember S, sympathetic, means it speeds up. So everything to do with the sympathetic nervous system is going to be sped up. So the heart rate is sped up. Conduction through the heart is sped up. We have more contractility of the heart. Okay, it's beating everything faster. More cardiac output. And the blood vessels, the arteries are going to constrict. So we're going to have an increase in blood pressure with sympathetic nervous system activation. Parasympathetic, that's also known as rest and digest. So this is going to be the opposite. So the vagus nerve will slow down the heart rate and cause the arteries to vasodilate. Sympathetic, you can also think of fight or flight with that system. Baroreceptors are pressure receptors that are located in various arteries, and they respond to increased pressure. So if there's too much volume, they'll change the blood pressure so that we don't have so much volume. They might slow down the heart rate a little bit or cause some other changes to help deal with that increased pressure. Decreased heart rate, peripheral vasodilation. So we're not putting as much pressure on the heart. And then chemoreceptors are going to respond to oxygen and carbon dioxide levels and also a decreased pH. So when the CO2 level is too high, they're going to change the respiratory rate and the blood pressure. When the pH is too low, when we have an acidic pH, or when we have low O2, we're gonna change the respiratory rate based on those chemical receptors. Okay, so remember that blood pressure, we've already talked about cardiac output, how that is the amount of blood that leaves the ventricles in 1 minute. And when we take the cardiac output and we multiply that by the systemic vascular resistance. Those two things are what determine blood pressure. Remember that pulse pressure, if anyone ever says this word, is just subtracting diastolic blood pressure from systolic blood pressure. And then mean arterial pressure is the amount of pressure over the entire cardiac cycle, including systole and diastole. Diastole is actually twice as long as diastolic blood pressure, so you have to multiply by 2. And then that when you divide that by 3, we really need an MAP, a mean arterial pressure of more than 60 millimeters of mercury, and a lot of the automatic blood pressures will calculate that for you. You don't have to calculate it. Remember that older adults are going to see changes. Their risk of cardiovascular disease, death from cardiovascular disease increases, especially once you hit 65. A lot of older adults are going to have coronary artery disease. They've had more time for that to develop. They cannot increase their cardiac output. It's much harder for them to respond to exercise or stress in the same way that someone younger can. They don't have the same cardiac reserve. And so it takes them longer to react, their cardiovascular system. The valves are going to cause some flow issues through the heart. Maybe they are stiff and they're not moving very well, so that can impact the flow of blood through the heart. They might get thicker. We might have blood moving backwards. That's called regurgitation. Or we might have narrowing of the area inside the valve. That's called stenosis. And these changes where blood flow is not going the right way, or it's blocked by stenosis, that results in a murmur. So we're more likely to hear a murmur in older adults. They're more likely to experience dysrhythmias or an abnormal heart rhythm. And their systolic blood pressure tends to increase significantly, which increases the pulse pressure. The vessels get a lot stiffer, thicker, plus they're more likely to have plaque, and so their blood pressure generally goes up. We're still going to treat hypertension. It's not normal for blood pressure to go up that high in an older adult, and so we will treat it. And then we do need to watch orthostatic hypotension, which is a decrease in blood pressure associated with position changes. So subjective assessment. These are all things that we're going to ask patients about. Are they experiencing symptoms right now that indicate they might have a cardiac history or a cardiac issue right now? Fatigue, they're retaining fluid, they feel their heart skipping a beat, they're having trouble breathing, chest pain, changes in neurostatus, leg pain, fainting can be a sign of a valve issue, heart valve. Do they have a previous history of alcohol use, chest pain, tobacco use? Have they had infectious diseases that might have affected their heart valve? Things like strep infection can affect the heart. History of hypertension or blood clots or edema. What medications do they take? In Table 35.2, it actually goes through a lot of medications that we wouldn't think would have an effect on the cardiac system, the cardiovascular system, and they do. And so we really want to look at all their medications, but we may want to look, more specifically at those drugs that we know affect the cardiovascular system. Things like blood pressure meds and diuretics and aspirin and anticoagulants have a big impact. But many, many drugs can impact the heart. Have they had surgery that's related to the cardiovascular system? Have they maybe been to the cath lab and had angioplasty or stents put in? So this is just a way of organizing a subjective assessment. And there are questions, some specific questions you can ask in Table 35.3 related to each of these. So, how are they managing their health in general, their nutrition, elimination, how's that going? Diuretics, we know, can affect their urine output and how much is coming out. Constipation and kind of bearing down can cause a decrease in heart rate. It's called the Valsalva maneuver. Sometimes we use that therapeutically. We have patients bear down to decrease their heart rate. What about their activity levels, how they're sleeping, problems with thinking, memory, concentration, how, what's their body image, their self-esteem like, how does their health affect their roles and their relationships, their sexuality. With cardiovascular disease, a lot of patients may have the fear of death if they, during sexual activity. Are they taking any drugs that might interact with their needed medications? Maybe they take nitrates for chest pain. They cannot take drugs like Viagra because it will drop their blood pressure. Hormones in women after menopause or contraceptives can increase risks for blood clots. So those are important things to think about. How do they manage their stress? How do the things that we're recommending as treatment, how does that fit in with their values and their beliefs? So physical exam, we're always going to start with vital signs. That gives us a lot of information about the cardiovascular system. For the peripheral vascular system, we're going to inspect, look for skin, look at their skin, look at hair growth. Do they have hair, on their legs? Because sometimes that goes away with poor circulation. Look for venous patterns, edema, varicose veins. We may see distended veins in the neck, in the jugular vein up here, if they're having trouble dealing with increased blood volume. If the heart is struggling to pump all that blood through, it can back up into the neck. We might see jugular vein distension. And we're going to palpate pulses. We're going to feel for temperature. Are the extremities cool because of lack of blood flow? Is there any edema? How's capillary refill? And then auscultation is really important in the heart. We're going to listen over the heart and see if we hear any murmurs in the heart, any bruits, which is a murmur that's not in the heart. It's basically turbulent blood flow in another place that indicates maybe some buildup of plaque. So in addition to listening to the heart, over the heart, and listening for S1 and S2, we're also going to listen over maybe some peripheral arteries and see if we hear turbulent blood flow there. We want to look at the chest. So here's a picture of the chest and where the heart is located and where we're going to listen. And the heart should fit in this space. If we're noticing that we're hearing or feeling the heart, moving over or moving down from this space, that's an indicator that the heart is enlarged, and that's an issue. So we listen to S1. Remember, that's the atrioventricular valves closing, also the beginning of systole, so the ventricles are contracting. S2 is the semilunar valves, so pulmonic and aortic valves are closing, and that is the beginning of diastole. We want to listen for any extra heart sounds or murmurs, and it's possible that you'll notice a pulse deficit, which is when you listen to the heart with your stethoscope and you feel the radial pulse. Are you feeling in the wrist every heartbeat that you're hearing over the heart? That can happen with atrial fibrillation. That's an abnormal rhythm where we can hear the heart beating extra, but it's not being transmitted out to the radial pulse. So this is an EKG, and it shows which part is systole, so when the ventricles are contracting, and which part is the ventricles resting. So you can see that during diastole, the atria are contracting, the right and left atrium are contracting, but the ventricles have not contracted yet. And you can see what causes the heart sound. So you can see that S1 is the ventricles contracting. It's this very, we have this big electrical peak. And S2, is the start of diastole. So some diagnostic studies, we'll start with blood studies. So when someone comes in and says they're having chest pain, some things that we can look for to see if it's related to heart muscle issues, a heart attack, myocardial infarction. Troponin is the biggest one. Troponin is not present in a normal, healthy heart. This is released when heart muscle dies. So if we see an increase in troponin, that indicates that the patient's heart muscle, some of it has died and this enzyme has been released. And you can see that it takes a little while for it to peak. So when someone comes in with chest pain, we're going to actually take 3 different measurements of troponin. They may also check for these other ones, but usually they'll do troponin levels times 3 every 8 hours to watch for this peak. Okay, and that tells us pretty easily if a patient has had a heart attack. CK&B is a specific creatinine kinase molecule that's released that's specific to the heart. And then myoglobin is another one that we might see. But troponin is probably by far the one that's used the most often. Homocysteine can indicate that someone's at risk for a heart attack, but it's not used quite as often. This natriuretic peptide marker, or BNP, tells us a lot about if a patient comes in and they're short of breath, and we think, well, it could be their heart. Maybe they're in heart failure, and that's causing the blood not to get to the lungs, to be oxygenated, and that's causing oxygenation issues for the whole body. And so they're breathing faster. We can take BNP, and BNP will tell us if that shortness of breath is related to a decrease in heart function or heart failure. And then serum lipids, these tell us a lot about coronary artery disease, about risk of heart attacks and strokes, because these are the substances that are building up in the arteries, the plaque that is coating the inside walls of the arteries and narrowing them and increasing the risk of heart attacks and strokes. So they'll monitor these, and there will be drugs that help decrease some of these levels. Remember that LDL is lethal. It's low density lipoprotein. And remember that HDL is healthy. It's high density lipoprotein, but it's healthy. We want this one to increase. We want more HDL, and we want less LDL. So you can think less LDL or lethal LDL, and you can think high or healthy HDL. Another thing we can do is look at a chest x-ray. A chest x-ray is going to tell us if the heart is enlarged. We can see the ribs, and we can see exactly how far the heart extends. And if it's extending too far to the left, we can tell if it's enlarged. We can tell if there's fluid in the lungs on a chest x-ray related to heart failure. We can do an EKG or an ECG. It's the same thing. I just find it's easier to say EKG. And this can be a one-time, we put it on and take it off. A 12-lead EKG where they put 12 different stickers on the patient. That's done for a very short time, and we just look at the heart from 12 different angles. or we can have a patient that's connected to a monitor or to telemetry, and they usually have between 3 and 5 leads. And so we can see the heart from fewer angles because each sticker is going to give us a different view of the heart, a different perspective. But they can wear that for a lot longer. It's hard. It would be hard to wear a 12-lead EKG very long. So EKGs that patients are wearing in the hospital when they're on telemetry, those are 3, sometimes 5 leads. And then we also have event monitors or loop recorders that the patient keeps with them for a little while. They go home with this, and it's activated by an event. So when something happens, it records it, and then they can send that to a cardiologist, and it can be examined. And then we might also do exercise or stress testing to see what happens when the heart is under stress. So that could be a treadmill test where they're monitored while walking or running on a treadmill. Or we might do stress testing with, they do some nuclear stress testing where the patient doesn't have to walk on a treadmill. They find other ways to kind of stress the heart a little bit and see what's going on. An echocardiogram, that is a special ultrasound, and that can be done through the skin. You can see pretty well what's going on in the heart, but the best way to do an echocardiogram is to actually put a probe in the esophagus and look behind the heart. Obviously, the patient needs to be sedated before we can put the camera into their esophagus. So you can do an echocardiogram that's non-invasive and get a lot of information, or you can actually sedate the patient and do a transesophageal echocardiogram. So nuclear cardiology, that's where they're using some radioactive materials, and they'll trace where that goes in the heart, and they can get some information from that. They can also do MRI to get a look at the heart. We can do CT scans. Actually, calcium scores are a CT scan, and those can indicate a patient's risk for upcoming cardiac events. And then cardiac catheterization. So we can take patients to the cardiac catheterization lab, and hopefully you guys have watched the video from the view of the patient. So this is a coronary angiogram, or angiography is kind of the whole kind of looking at the vessels. So angio means vessel, and then graphy means we're going to write something, we're going to take a picture of what's going on. So an angiogram is the actual picture. Angiography is the procedure, but they're going to inject radioactive dye, and they're going to use an X-ray and watch where that dye goes. Does it go into the coronary arteries? Do they see any areas that are narrowed that might need an intervention? Like an angioplasty, which is the balloon blowing up, or a stent, which is actually blowing up a metal cage to hold the vessels open. If there's multiple vessels that are blocked or narrowed, they're going to take the patient for surgery and do bypasses instead of repairing it from inside the artery like they can do in the cardiac catheterization lab. They'll actually take them to surgery. An electrophysiology study can also be done in the cardiac catheterization lab, or they may have a separate lab that they do this, but this is looking at the electrical system. And so if there's a conduction issue, sometimes they can fix that in the catheterization lab in the same way that they can fix artery issues. So the artery issues are usually considered kind of the plumbing of the heart, and then the electrical system would be the conduction system, the EKG. The end.